Hello everyone. Today we'll be talking about the glomerular filtration and peritubular capillary absorption. In the previous lectures, we learned that there are many things that affect your urine output, and these include your renal blood flow, amount that is filtered, and amount that is reabsorbed. And to understand the urine output, you have to put all these three things together to understand why your patient urine output is decreasing. In this lecture, we'll focus on the physical mechanisms, GFR and peritubular absorption. We learned from our previous lecture that there are three types of capillaries: continuous, fenestrated, and sinusoid, and kidneys have fenestrated capillaries. There are three layers that separates your capillary lumen from Bowman space. The first lining is your endothelial cell with its Glycocalyx membrane, basement membrane, and foot processes with slit pores. Glomerular basement membrane is made up of type 4 collagen along with laminin and nidosine, and it has got heparin sulfate, which is an anionic proteoglycan, and we'll see its role in subsequent slides. The important thing to understand in glomeruli is that glomerular walls are size selective. If you look at the fenestrae, they are around 37.5 nanometers, and the basement membranes have small pores up to 4.2 nanometer in size. Because of the large size of albumin molecule, this molecule is unable to pass through. However, in endothelial injury, you can see that albumin can leak. However, it will collect at the base of endothelial membranes. Second thing is the charge selectivity. Both the glomerular basement membrane and the glycocalyx are negatively charged. Since albumin is negatively charged as well, it is unable to pass through these two membranes. So Steverman's constant for albumin is 1, as this molecule is both large and negatively charged. So size and charge selectivity are important in your glomeruli. As your molecular weight increases, your radius increases, and so your filtration decreases, and we use a term called sieving coefficient to describe it. The effect of charge is shown in this figure. For the same molecular radius, you can see that negatively charged dextrin is less filtered than a positively charged dextrin of the same molecular weight. So smaller and cationic molecules are filtered more, and larger and anionic molecules are less filtered. Please watch my earlier videos on modified Starling model to understand these concepts in more detail. GFR, like in any other capillary bed, depends upon your hydraulic permeability coefficient and surface area multiplied by the hydrostatic pressure gradient, in this case glomerular capillary pressure minus Bowman space, and difference in oncotic pressure between plasma and Bowman space. Since Steverman reflection coefficient of proteins is 1 in glomeruli, there is hardly any protein in Bowman space. So this modifies the formula to simply permeability coefficient multiplied by surface area multiplied by hydrostatic pressure gradient minus oncotic pressure in the plasma. Permeability coefficient and surface area of glomeruli are 50 to 100 times those in muscles. Therefore, the rate of filtration is very high, and this is aptly suited to kidneys as they need to get rid of a lot of waste materials. Watch my earlier videos where I talk about the different permeability constant and surface area in different capillary beds in the body. The links will be in the description below. Total glomerular surface area is around 500 centimeters square, which is equal to size of an iPad Pro. The mesenchymal cells are interesting as they can change the surface area by contracting and relaxing, and so can the pressors. Another interesting fact is your glomerular capillary pressure are markedly higher than the pressure in the normal capillaries. We know that the total renal blood flow is around 20% of the cardiac output. That would be around 1000 ml per minute in resting state. Total rate of glomerular ultrafiltrate production in normal kidneys is about 200 ml per minute. And when you divide by the body surface area of 1.72, that gives you 100 to 125 ml per minute per meter square, a number that you must have read in your textbooks. The hydrostatic pressure gradient usually decreases along the capillaries, as we have seen earlier, but in the glomeruli, these don't change much, as your pressure on the afferent side of the capillary and efferent side of the capillary are pretty much constant. So your net outflow hydrostatic pressure gradient remains constant throughout the glomeruli. Since kidneys are encapsulated organs, the intrarenal pressure that developed in the kidneys are also transmitted to the glomeruli. Since the permeability coefficient and surface area of glomeruli and the hydrostatic pressure gradient is pretty large, there's a lot of net movement of fluid out of the capillaries. And since proteins don't move out, your plasma oncotic pressure rises rapidly. And a point comes when your oncotic pressure equals this hydrostatic pressure gradient, and it slows down the filtration. So let's look at the fluid movement through the glomerular capillary. Your hydrostatic pressure gradient is around 35 to 36, and your oncotic pressure gradient increases as you move from the afferent to the efferent side. And a point comes when oncotic and hydrostatic pressure gradient are similar, so the net flow drops down to zero. Interestingly, this occurs when you lose 20% of your plasma. Once you lose this amount of volume through GFR, your oncotic pressure in the plasma equals hydrostatic pressure gradient. And the point where there is no net flow is called filtration equilibrium. This does not happen in other capillary bed because the net movement of fluid is much smaller. It only happens in glomeruli because of large amount of ultrafiltrate. So GFR cannot exceed 20% of the renal plasma flow unless you increase glomerular capillary pressure or reduce plasma oncotic pressure. Even if the membranes become more leaky, you still reach that equilibrium after losing 20% of the plasma. So your filtration equilibrium occurs much earlier in the capillary bed, while the total amount of GFR remains the same. So why 20%? So we understood that renal blood flow is around 1000 ml per minute, and the initial oncotic pressure are between 24 to 28 centimeter of water. So the oncotic pressure required to match hydrostatic pressure is around 35, as we have seen previously. And you can calculate that after losing 200 cc's of ultrafiltrate, this new oncotic pressure is 35, which is equal to the hydrostatic pressure. And this 200 cc's is around 20% of the renal blood flow, that is 1000 ml per minute. So total rate of glomerular ultrafiltrate production in normal kidneys is around 200 ml per minute. In normal condition, hydrostatic pressure is heavily regulated and plasma albumin concentration does not change much, so this rate remains pretty much constant. There's another graph that some textbook will give you, so let's understand that. So on the x-axis, we have glomerular capillary length, on the left is afferent, and on the right is efferent side. This is your glomerular pressure, and in red is Bowman space pressure. Initial pressure is shown at the beginning of glomerular capillary on the afferent side, and as you get more filtration, the oncotic pressure gets higher and reaches capillary pressures, and that's when the filtration stops, and that point is your filtration equilibrium. Let's understand how this affects your day-to-day maintenance of GFR. Say you're hypovolemic and your renal blood flow has decreased by 50%. Understand that your hydrostatic pressure gradient will have remained the same since you're auto-regulating, and your filtration equilibrium will still be reached after 20% of loss of renal plasma flow. So since your renal blood flow has dropped by 50%, your GFR will drop proportionately by 50% as well, so that to reflect 20% of that renal blood flow. Say you have renal blood flow that is increased by 30%. Again, the same thing will happen. You will reach the filtration equilibrium once 20% of that renal blood flow has been achieved. So your GFR will increase by 30% as well. Renal blood flow is an important determinant of GFR. As your renal blood flow drops, so will GFR. Filtration fraction can be written as amount of GFR divided by the renal blood flow, which is around 20%. Rearranging this equation, you get GFR equals filtration fraction multiplied by the renal blood flow. So your GFR can increase by only three factors. First, by increasing your filtration fraction, which depends upon glomerular capillary pressures and plasma oncotic pressure, and by increasing renal blood flow. So increase in PGC or decrease in plasma oncotic pressure will increase the filtration fraction to more than 20% and vice versa. So let's understand this more intuitively. As you increase your glomerular capillary pressure, you can see that filtration equilibrium is shifted to the right. So you are filtering at a higher gradient for a longer length of capillary. So your filtration fraction will be higher than 20%. If you drop your plasma oncotic pressure, the similar thing will happen. Your filtration equilibrium is shifted to the right, and you have a longer length and higher gradient at which your filtration can occur. So your filtration fraction will increase to more than 20%. Let's see what happens during constriction of afferent arteriole. As your afferent arteriole constricts, your glomerular pressure drop, and your filtration equilibrium is shifted to the left. And it also results in decreased renal blood flow, and both result in drop in GFR. So constriction of the afferent drops your GFR. Let's see what happens when you constrict your efferent arteriole. As your efferent arteriole constricts, glomerular capillary pressure increases, so this shifts your filtration equilibrium to the right and increases your filtration fraction. However, this also decreases your renal blood flow, so the net effect is maintenance of your GFR. So as your efferent arteriole constricts, your GFR remains the same. However, if you continue to constrict further, as seen in more severe shock state, your filtration fraction is going to drop because your capillary pressure are now much lower and renal blood flow has dropped further. And as this worsens, your GFR drop. So severe constriction of efferent arteriole will also drop your GFR. Even if your permeability of your capillaries increases, your filtration fraction remains the same because now you can achieve the filtration equilibrium much sooner once your 20% of your plasma has been filtered. If your permeability decreases, everything shifts towards the right. However, you still reach your 20% of your filtration fraction just later in the capillaries. However, in CKD, because of decreased permeability and possibly damage to your glomerular capillary length, your filtration equilibrium is not achieved, so your GFR drops. Now that you know all these principles, let me know which will result in higher GFR, a liter of 5% albumin or a liter of normal saline. Write your answer in the comments below. Next, let's talk about peritubular capillary uptake. Absorption in peritubular capillaries is really important. If your amount of filtrate is not reabsorbed, your kidneys are going to lose a lot of fluid and you can become dehydrated very quickly. The capillary pressure in the peritubular network is much lower, to the order of 13 centimeters of water. However, because of the filtration of water in the glomeruli, the oncotic pressure in these capillaries is much higher. So net gradient is towards the movement of water towards the capillaries, and the uptake gradient is around 13 millimeters of mercury. The net flow in peritubular capillaries is towards the capillaries, and as you move towards the end of peritubular capillary, the oncotic pressure gradient falls as it gets more diluted. Peritubular capillary hydrostatic pressure is regulated by the glomerular arterial tone. That means if your afferent or efferent arteriole constricts, peritubular capillary pressures will drop. The oncotic pressure in the peritubular capillary will depend upon how much your baseline plasma protein concentration is and the filtration fraction. The more you filter, the higher the oncotic pressure gradient in peritubular capillary will be. So let's see what happens if you're hypovolemic. Your angiotensin II and your sympathetic nervous system are going to get stimulated and will cause vasoconstriction. Both of them will result in a decrease in renal blood flow. And since you have vasoconstriction, peritubular hydrostatic pressure is going to drop, let's say from 13 to 8. However, since your efferent is constricted more than afferent, your filtration fraction increases, so oncotic pressure in the peritubular capillary would be much higher. This results in net inward movement of water in the peritubular capillaries. So when you're hypovolemic, just because of these new pressure gradient, your PTC absorption increases. Of course, there are other changes happening on absorption of filtrate as well. For example, we talk about autoregulation, tubuloglomerular feedback, hormonal influences, vasopressors, etc. In summary, glomeruli are both size and charge selective. Smaller and cationic molecules will be filtered more. GFR cannot exceed 20% of the renal plasma flow without increase in glomerular capillary pressure or reduction in plasma oncotic pressure. GFR increases only with three factors: increase in glomerular capillary pressures, drop in plasma oncotic pressure, and increase in renal blood flow. And if you filter more on glomeruli, you will absorb more in the peritubular capillaries. This video was mostly to understand how glomerular forces work. This should help you construct a basic understanding of GFR, and we'll learn some of the clinical aspects of this in the next lecture. Thank you.